Hi, welcome to CIVHC Change Agent Chat episode 26. During these chats, we speak with change agents who are working to create a better healthcare system for us all. I'm Stephanie Spriggs with the Center for Improving Value in Healthcare, or as we like to call it, CIVHC. In this chat, Tamaan Osbourne-Roberts, CIVHC's former CMO, is speaking with Melanie Plaksin, VP of Market Growth for DispatchHeatlh. DispatchHeatlh works as an extension of primary, specialty, and home care by delivering simple to complex medical treatment in the convenience of the home. Using different mediums, including a free mobile app, website, and telephone, patients, clinicians, and caregivers can request on-demand care. During this chat, we learn about the challenges in setting up a new model for healthcare delivery and the types of outcomes DispatchHeatlh is seeing. We recorded this chat in April 2018. Thanks for listening and enjoy the chat.
Good afternoon, Colorado. How is everyone doing? Well, you can't answer. No. In all seriousness, it's really great to have everyone back again for yet another Change Agent Chat here with CIVHC. I am the Chief Medical Officer of CIVHC, Tamaan Osbourne-Roberts, and we're really happy to have you here with us today. Today we'll be talking with someone from DispatchHeatlh, and we'll talk a little bit more about them today. But just really wanted to go ahead and remind everyone of a few things. One is that we would love for you to send us questions as we have the conversation today, and you can do so in the question and answer portion of the Zoom chat. In addition to that, we'd like to remind everyone to remain on mute. And aside from that, we'll go ahead and get started. So today we have a very, very special chat. It's a little different than what we have done for a little while. Namely, we're actually not going to necessarily be talking about civic data. One of CIVHC's roles in the community, as you know, is to serve as a convener for the various people who are out there on the ground making change happen in the health and healthcare ecosystems. And we're lucky enough today to be looking at somebody who's making a huge change happen. Today we have Melanie Plaksin from DispatchHeatlh with us. DispatchHeatlh, Melanie, I will let you take it away and tell us a little bit about DispatchHeatlh, who you are, how you started, and what you do.
Great, thank you. And I'll try and keep this fairly brief so that we have opportunity for more discussion. But DispatchHeatlh started in 2013, more or less, as a proof of concept to understand how much of unnecessary ED utilization could we pull outside of the brick and mortar setting of an emergency room and deliver directly at somebody's true bedside in their home or where they're really comfortable. So we started as a pilot because truly you have to test this concept, right? It's really difficult to say how much of the emergency room can we bundle up in a car and take to somebody's home. And the way that we did that is we actually embedded with one of the local 911 systems in Denver, South Metro Fire Rescue, which gave us an immediate patient population. So what we did is for your low acuity calls, if somebody called 911, we would dispatch out alongside the ambulance and give the individual in the home the opportunity to say, I feel comfortable being treated on scene, or no, please transport. The interesting part of that, that entire study was we really were able to refine and understand clinically what our capabilities were, what we needed in the car. And I'll just give you an example. We started with a really large pumper truck, right? And then we shrunk all the way down to a Prius in terms of space. But most importantly, we were able to understand, do patients feel comfortable being treated in their home? Are they, is the quality of care that's being delivered in a home environment really good, as well as is there any cost savings? And so we were able to prove all of those things through that 18-month pilot. That ran 2013 to 2014, and just at a really high level, to give you an idea, we were able to see 96% of the individuals that were Alpha Bravo calls through 911. Of those folks, that was about 400 patients. Of those folks, we had a less than 3% bounce back rate to the emergency room for same or related symptom, and we saw cost savings of close to $1 million. So pretty incredible, right, for proof of concept. Yeah, and what that, what that allowed us to do was understand that what we were doing was good, right? It was good care, quality care, and really patient-centered. What we did is we took that data to both payers to establish relationship from the insurance side or carrier side, as well as we took it to investors. So we've been up and running as DispatchHeatlh since August of 2015. That's in Denver, right? That's where we originally were started. And the way that it really works, it's pretty simple, right? So you call us to request care, or something acute occurs. You can call to request care. You can request care through a mobile app because we live, in the century of smartphones, and that's how people maybe want to access care. Or you can request care through the web, which I think is really important. So we meet the patient where they feel most comfortable. We do have a pretty sophisticated risk stratification that occurs when you call us. So we're not going to come out if you have chest pain with shortness of breath, right? So if it's life-threatening, time sensitive, we will divert you to the emergency room. However, if we feel like we can provide safe, definitive care on scene, we give you an estimated time of arrival. We're on scene 45 minutes to an hour on average. It's a nurse practitioner or a physician assistant alongside an EMT, and we treat the entire lifespan as well, right? So we are treating pediatrics all the way through geriatric. I think the most important thing about what we do, in addition to the level of care we're able to provide in the home, is we follow up with your primary care provider, right? So we're coordinating care as a follow-up, and we're creating some level of continuity of that care as well. If you go into the emergency department, your PCP may or may not understand that you were there. We are sending notes 100% of the time, right? So our encounter summary goes to your PCP. It may also have captured some social determinants if that's appropriate. We may have done some medication reconciliation, again, if it's appropriate, in addition to providing that care on scene with you. We call our patients 3 days after, we bill their insurance, so on and so forth. So really pretty simple in terms of how we're delivering care in the home.
Okay, that's overall pretty incredible. I mean, if I can reflect that back a little, it almost sounds like what you're doing, for healthcare is Amazoning it, if I can put it a certain sort of a way. Because it used to be that, for instance, retail, you'd go to a little mom and pop shop, and then we moved to big box stores where you could kind of do everything in once, but you still had to leave your house and nothing was online. And then you moved to those being online, and now you can conduct everything online with payment and requesting something and receiving it, returns everything in really one place that's super convenient, fits modern lifestyles, and provides a better experience, for less cost. It almost sounds like you're even a step ahead because you're not delivering an item, you're bringing healthcare and improved health to people this way, and you're able to do it in an incredibly complex fashion. Am I hearing you right?
Yes, I think a quick 6-minute overview that's a good way of, I think, pulling it together. We utilize a quote that Mark Bertolini, who's the CEO of Aetna, often says, and that's convenience is the new quality, right? So when we look at our key performance indicators as a company, we're always looking at patient satisfaction, and our patient satisfaction scores have never dropped below 90. We're utilizing Net Promoter Score, which is on a Likert scale, right? How likely are you to recommend this service to a family member or friend? Industry average is around 30. This last month in Denver, my clinical team was at 98. And that's with a high response rate from our patients as well. But I don't think what we're doing is necessarily magic. It's just that we're going directly to the patient rather than the patient having to come to us. We're billing their insurance. It's a lot less than going to an emergency room. And then we're communicating, right, on their behalf as well. So.
Okay, no, that's fantastic. I mean, this is an amazing idea. Can you tell us a little bit more about how it started? Was there a particular experience that somebody had, or was there some other thing that brought this together?
Yeah, so we have two co-founders. One, his name is, and he's our CEO, his name's Mark Prather. He's an emergency medicine physician, right? And he had worked locally in Denver, as well as staffed many of the emergency rooms around Denver. And so he was constantly looking at the nature of an ER, right, and this acute care problem that is the emergency room, being that it's an expensive place to receive care. Patient experience isn't great because you're spending very short or minimal amount of time with your providers. You're seeing multiple people during that stay, right? You may feel like you've gotten forgotten about at times, and you leave and communication may or may not have occurred with your PCP, or there may not be a very clear care plan in place for you as an individual. So because of that, and if you look at data, I think what's really interesting is, about 40% of folks who go to the ER, it's unnecessary. They have non-urgent needs. And there's an additional 20% that we would argue have urgent but not emergent needs. So you're talking a substantial amount of people that could be treated in a more comfortable place at a lower cost, and be able to spend a much longer time with their provider as well. Okay, no, that's really
great. Fantastic. I hate to put you on the spot, but I'm wondering, can you think, as we can see, you're in your car right now. Clearly, that's a beautiful conference room you have.
It's lovely, isn't it? My computer's here, it works well. Very fitting for dispatch.
And there you go. And clearly, because of that, you yourself are moving to and fro. Can you think of a particular patient story that's come up as you've done this, where in comparison to what a patient might have done otherwise, they just had an incredible experience or an outcome that was just great for them?
Sure, I can use 2 examples. So I do quite a few ride-alongs with our provider teams as well, so that I can see how care is being delivered in the home. And we went and saw a patient who had pneumonia. He had called with severe cough and weakness, right? I think is what his chief complaint was that we went out on. And I'm not clinical, so keep me honest here. We went out into the home, and I thought what was really interesting, we got there, he was able to come and open the door, but what we did is where he was most comfortable was laying in his bed. So we went directly to his bedside. He laid in his bed the entire time. We did a flu test while we were there, right, flu swab. We also ran IV fluids, we started IV meds, so on and so forth, all while he laid in bed. And it was really incredible, I think, just to see the clinical team and how they were interacting with the patient. They went down to his kitchen to get him more water because that was a request. They were able to bring him tissues from his bathroom right directly to his bedside, so that he really didn't have to move from his bed and was able to lay there where he was comfortable. While we were in his home, they called his daughter, who was very involved in his care as well. We had her conferenced on so that he could also be communicating with his daughter that entire time, right, about how he was feeling and how it was going. His wife was actually in the hospital and hospitalized, so he didn't have that support system at home. It was really his daughter who was on the phone. She was at work, but she was going to be able to stop by later in the day, and we were able to care for him while he laid in bed. When we were leaving, the mobile imaging company was getting there to then run the chest x-ray, right? We also sent the electronic script to his pharmacy of choice. His daughter was going to pick it up, but we had already started his immediate medications while we were there through IV. So I just think overall, it was an incredible experience to watch. We were in his home, I think, for an hour and 10 minutes about providing care. And he never had to leave. He got to lay there the whole time. His daughter was put at ease because we were in his home and she didn't have to worry about her other parent then going to the emergency room, right, and potentially risking a hospitalization. We billed his insurance immediately following, and we also called his PCP because we wanted him to know exactly what we treated his patient for.
No, that's
a decent example.
That's a great example.
Yeah, it's a great example. On the other side of the spectrum, last week we had a patient, mom who had 2 kiddos. All were very ill, including mother. She didn't feel good enough. She had severe nausea, vomiting, didn't feel good enough to get in the car and drive all 3 of them right out of the home. So we went to her house. We actually treated each kiddo and mom while they laid in their beds in their house. We just essentially went room to room. So I think that's another interesting example, very much on a different spectrum. But if you start to look at, there's physical and sometimes social mobility challenges that individuals have, and if you're able to bring that care to them, there's a comfort piece there, as well as there's not maybe the anxiety of having to worry about transport into another location.
Yeah, no, I mean, as I listen to you as a provider myself, as a physician, really what I'm hearing to some degree, what I'm thinking of is you're getting rid of the walls, and some of those are physical walls, which are, if somebody can't leave their own home, or it's very difficult, even if they can't leave their home, to get into a hospital or a clinic situation, those walls go away. You bring people together, and then you're getting rid of the metaphysical walls, if you will, as well. The anxiety of having to leave your own space, and the socioeconomic barriers that prevent a lot of people from being able to, take time or space out of their day to really be able to do this. It sounds like, really it's just walls are coming down, and you're bringing the experience of care and the experience of the patient into the same space, which is not something, frankly, as a physician who practices in a traditional setting, I'm able to do. Forget want to do. I might want to do, but I can't.
Yeah, sure.
No, that's really, really incredible. Now, it's been said, I've heard it been said that a lot of the innovation in healthcare, not health necessarily, but healthcare at least, is operational. When it comes down to it, a lot of industries talk about, you build a platform and then you scale it, and then you sell it and you IPO. And a lot of what we do, and what I'm hearing from you is that the challenges are operational, and you have to get the operations to work. Inside of that, what challenges have you really had, as you've been working on this? To move from an idea to reality always takes a few steps. And can you tell us about some of the hiccups and how you address them along the way?
Sure. I think, so I've been with the company since we started, and I've watched this as we've progressed over time. But one of the biggest challenges that we continue to have is, how do you stay top of mind, right? So you can operationally figure out how to be sound as an organization, but then how do you change behavior that people already have? So people's behavior today is to immediately call 911, right? Or go to the emergency room. We work very closely with physician practices as well. So think, if you're on call as a provider, and you want us to see your patient, you have to remember, right, that DispatchHeatlh is an available resource, so that you don't potentially have to send them to the emergency room. So that's one big piece. A second piece that's been really interesting is also having the ability to gain trust of an individual, or if a physician is making that referral to us to go see their patient. I think we're starting to be in a day where you understand quality outcomes based on a hospital, right, location, an ED, urgent care. You know which ones are quality driven, but we're an entirely new care delivery model. Our clinical outcomes are incredible, but I think to gain trust in us coming into your home, for starters, and then if you're a physician and you're making the referral to us, there's that component as well. Now, we've had very interesting ways of overcoming both of those here in Denver, but we have started to scale. So now we're in new cities, and we're seeing some of those same interesting dynamics occur in each new city that we enter into. I will tell you, once you start to get just those initial patients and those, I would say, provider leaders within a community to utilize your service, they become really brand ambassadors, and they have been critical to our success as well.
Got it. So it sounds like, part of the challenge is coming up with the idea to start. Another piece of the challenge is making it into something. And then, if you will, the final part of the challenge, which I personally think sometimes we don't always appreciate in healthcare, is behavior change. Is, getting people from what they've done to what they perhaps would like doing better. That mythical quote, if you will, by Ford, who said, if I'd asked people what they'd wanted, they would have asked for faster horses. It looks like avoiding the faster horses is something you've really worked on and you've really, really pushed.
Yeah, and I think, no one's done this before. So it's been, you had traditional house calls, right, 1940s and earlier, and then that dropped off. And now we have technology infrastructure that we can utilize to support us, right? So an EKG, it's like in a backpack that we take into the home. Our lab capabilities are all, they're minimal, right? They're small in comparison to what they historically were, but it's like it's an entirely new delivery model. So there's pieces where we're just like, how do you do this? Like no one, we're figuring it out as we go, but it's been really fun. Yeah.
Oh, I got it. Well, it looks like we're starting to get a couple of questions here, and let me go ahead and throw those out. Wanted to remind everyone who's listening, please throw some questions into the question and answer, because we really want to know what you want to know, and we want to discuss what's on your mind about this incredible new model. So the first question we have is the cost of the service. What does this typically cost patients? Does it have a different model than typical care? Is it similarly billed? How do you do it?
Yeah, so that's a great question. We actually have a case rate so that we can be really cost transparent, right? So if an individual calls us based on their insurance, we're able to tell them the exact cost of care. If you have a traditional plan, it generally looks like your urgent care or your specialist copay in terms of cost, depending on your insurance carrier. If you have a high deductible plan, it's a case rate that's somewhere between, we generally use $200 to $300 as the benchmark, and we're able to tell you that exact cost. We also have a self-pay rate of $275. Now, I will tell you that cost is total cost of care. So if we come into your home and we're doing IV fluids, IV meds, sutures, we so on, like labs, so on and so forth. That's total cost of care in terms of what DispatchHeatlh is delivering in your home. So very minimal in comparison to that of an ER.
Okay, and in your experience, how does that compare to, say, the average cost of care in emergency departments? I know it's different market to market. You just pick one, or care in an urgent care in a given market?
Yeah. The easiest way, I think, to talk about it is 8 to 10 times cheaper, right, in terms of cost. The other piece is you don't get a level of transparency when you walk into an emergency room. And one of the larger challenges that we're seeing in Colorado is freestanding, right? So you can go into a freestanding ER thinking that you're going into an urgent care setting, maybe have a urinary tract infection, and end up with a bill for $3,400, say, right? That was an example that I think 9 News did a cover story on. And so, that it all varies depending on cost. We use an average of, $1,500 to $2,000 in terms of what the average cost of an ER, and then we're between $200 to $300.
Which is just absolutely fantastic. So another question: how does a patient who's home alone and isn't able to drive to a pharmacy get the prescriptions that get prescribed during the visit?
So if they're home alone and they're not able to get there, that's a really good question. So we generally try to work with their social, surrounding, whether it's the example that I utilized earlier, it was his daughter who actually went to the pharmacy and was able to pick up those medications. In some cases, we do work with companies that deliver medications to the home. I'll use Innovage as an example. They are able to deliver medications after DispatchHeatlh is out and treating one of their participants.
Got it. So it sounds like in the care experience as a whole, you're not just, there's obviously mobilizing the experience of direct person-to-person healthcare, but there's also a component in here that you're doing coordination of care that is perhaps normally more difficult to get in an urgent care or an emergency department, and actually saying, okay, we realize your primary barrier here may be something that's related to the health piece, that sounds like another innovation.
It is, yes. And I will tell you, we've gotten to those patients where, say, it's a holiday weekend or something's a little bit more difficult in terms of getting out. We have enough medications where we can use a few doses, right? So if we need to leave a couple of doses behind, we can do that as well, which I think is important to note. So we're always looking at how do we make this easiest for the patient so that they don't have to potentially jeopardize their care or end up in another setting.
No, got it. And, with a 3% bounce back rate, it sounds like you're optimizing that pretty.
Yeah.
Well, Another question, in Colorado or really in any of your markets, will Medicaid pay for the service?
Yes, so Medicaid, Medicare, and TRICARE are all payers that we work with as well. And then we have relationships with all major payers, including Medicare Advantage plans.
Got it. And in really getting payers to come on board, since, Civic, works a lot with data, you talked a good bit about your data and your outcomes. Was that key in opening up those conversations or in closing those sorts of partnerships and agreements?
Absolutely, because I think there's a couple of components there, right? We're an entirely new delivery model. We may be a little bit more expensive than just an urgent care visit, and so how do you communicate that to your patients? If you're an urgent care copay, that's one thing, but if they have a high deductible care plan, you want that transparency of cost. And then the other piece is, how do you make sure that you're not taking over primary care patients either, right? So we're not primary care. We act as an extension of the care team that exists today for that patient, right? For after hours, weekends. If there's not same day capacity, we're able to treat those patients. And it's a part of our entire risk assessment. So if a patient calls us and it's an inappropriate utilization of DispatchHeatlh, we will have that conversation with the patient as well, which I think is critical for payers to understand too. We understand and we are firm believers that primary care is a critical piece to an individual's care team. And we want to make sure that they're tucked in. We're not stepping on those toes, if you will, and we're tucking those patients back in. Another component of that, I will tell you, if a patient calls us and they don't have a PCP, we do have a repository of physicians that are accepting new patients, and so we can make those referrals as well, because we do want a patient to establish a relationship with a primary care provider.
Well, I'll say as a primary care physician, that is music to my ears.
Well, good.
Fragmentation of care is a real issue nowadays, and it sounds like you're working in the exact opposite direction. You want to make sure folks have, that medical home, if you will, and a place they can go to really plug in everything, and that's really. I would say that as I really listen to you talk, you've really laid things out really well. I'd like to give you an opportunity to really talk a little bit about where you think this is going to go, and what your next ideas and steps are. Some additional innovative things that you're kicking around. You don't have to make any promises. Just because.
Sure. So I think, and I didn't speak to this that much, but the other side of our company, as much of a clinical practice, we have a very significant, sophisticated technology infrastructure that supports our teams mobily, as well as makes for a very interesting and seamless patient experience. So where I see this going is I do think that there's a place for home-based care overall, and I do think that the acute care delivery in the home adds a lot of value, right, as well, in terms of quality outcomes that we're seeing, especially if you look at very frail populations. The ability to not have to worry about 911 transport into the ER, risk of hospitalization, and then potentially get discharged to, say, SNF, right, or some other acute, across the continuum of care, another facility type. So I think that there's a place for it, but I think that we can continue to build our technology to help support that experience and make it more and more seamless. And I'll give this example. We just launched a tool that we call our narrow network, right? So we can pull up and we can say, okay, Melanie Plaksin has United Healthcare. This is exactly where you can send her medications to. This is where she can get her x-rays done. This is where she can get XYZ done, right? So that it stays in network for me as an individual, and it contains cost for me as well. So I think that's a component of it. I think continuing to build and grow on social determinants of health is really important as well. When you look at cost for individuals, if they have 1, 2, any functional impairments, right? It doesn't matter how many chronic conditions they have. They're more costly as an individual, but also there's, I think, significant opportunity to support that individual with community resources if you can identify it in the home. And that identification is key, but then what do you do about it? And that's, we've been able to identify. Now it's how do we really coordinate care, identify those community-based resources that automatically we can tuck that patient into, whether they don't have adequate access to transportation or food, or right, we're looking at their activities of daily living, so on and so forth. So that's where I see this continuing to morph, where we're looking at, you know, truly driving for the individual the ability to age in place, to support them effectively outside of the walls of a hospital. And when you talk about medical home, right, we're integrating across the board to make it just a good care experience for them.
And the medical neighborhood.
Very long-winded answer. Yeah.
No, that's a great answer. I mean, the way I'd say is you're eventually looking to move from being a healthcare company to a health company, as it were, you know.
Yeah. Yeah,
that's,
sure.
That's the way to go with this incredible platform you have. Well, the time went really fast. We've come up on 12:30. I did want to give you a chance to, you know, make any final, you know, sort of, you know, plug statements or anything that you'd like to do, and go from there.
I mean, I think if individuals are interested or they want to learn more, they're welcome to reach out to me directly. And so I'll give Civic the opportunity to share my contact information. You can find more if you go to DispatchHeatlh.org or .com, sorry, DispatchHeatlh.com. We'll continue to push out, I think, more information as we continue to expand and grow as a company. I appreciate your time today. Thank you for inviting us.
No, absolutely, and thank you so much for spending time with us, and thank you to everyone who has tuned in today to listen. I'd like to remind everyone, once again, we'll be having another one of these in the upcoming month, and you should look into your email and keep an eye out for that. Additionally, this particular chat will soon be uploaded to the Civic website, so if you'd like to pass it along to various other folks, there'll be an opportunity to do that. Thank you very much. Thank you, Melanie, for joining us today. Thank you to all of our participants.
Thank you.
And we will see you again soon.
Thank you.